with Kawita Bapat, a platform for conversation, insight, and knowledge sharing and the take work passages, especially the crisp knowledge about the various subjects through the conversation with leaders and experts in their respective field. Our goal is to provide practicing doctors with access to the valuable information, knowledge, and that can help them to go progressively, professionally, and personally. Today, I'm really proud and privileged. This word, I don't use it, but still I want to say that we are having a very senior most surgeon of the town, Dr. Ashok Ladha. He is exceptional medical professional who has made a significant contribution into the field of coloproctology, and his achievements and dedications in the advancing specialty have brought him widespread recognition and praises. I'm just enumerating few of his commendable aspects of his career. The academic excellence, Dr. Ladha sir has academic journey began at MGM Medical College, where he completed his MS degree in 1977. The solid foundation laid the groundwork for his subsequent achievements in the field. The international training seeking to enhance to his expertise, he has pursued the specialized training abroad and successfully obtained the fellowship of Royal College of Surgeons, taking the FRCS from the prestigious Royal College of London. Subsequently, he underwent further training in coloproctology surgery in the United Kingdom, Switzerland, and United States. Being an accomplished person, he has a professional membership were acknowledged by medical community, and he was awarded membership in the esteemed American Society of Colon and Rectal Surgery, ASCRS, in 1983. His ongoing dedication to the field is evidenced by his current status as Honorary Senior Fellow of the Society. He has established a coloproctology as a super specialty. After his return to India, he embarked as a mission to establish coloproctology as a recognized super specialty within the country. Through his untiring efforts, and he succeeded establishing the national program of training of coloproctology under the auspices of the Association of the Colorectal Surgeon, auspices of the Association with the Colorectal Surgeons of India, ACRSI, in 1997. Furthermore, he founded the fellowship in coloproctology, FACRSI, in 1999, which has become one of the most sought after training and the fellowship programs in India. He has a great leadership abilities and especially skills and commitment to the medical community, which is evident through the prominent positions with the professional organization. He served as the president of ACRSI in 2004, demonstrating his ability to guide and shape the direction of the association. Additionally, he dedicated 7 years as a governing council member of the Association of Surgeons of India and further contributing to the advancement of the surgical field. To my really the nice way, it's a master trainer. He is a master trainer in Pakistan in 2006, and he has recognized his expertise invited by the government of Pakistan to serve as a master trainer. He played a pivotal role in training surgeons in the specialty of coloproctology and establishing an annual training program that continues to be highly regarded and popular in Pakistan. And really happy to tell about it that he is a founder, established his commitment in the raising awareness of promoting education of coloproctology, extends globally, and he is a founder for the World Piles Day. In 2006, he established World Piles Day, and which is observed every year in November 28th. The initiative serves as an important platform and should shed light on the piles and its management, ultimately benefiting the patients worldwide. He is a pioneer of restorative proctocolectomy, and he was introduced and established the technique of restorative proctocolectomy or ulcerative colitis in India back in 1985. His expertise in the procedure unparalleled and successfully operated in a large number of the patients over the last 35 years. Long-term follow-up demonstrates remarkable surgical skills and commitment to the improving patient life. and innovator of SEPTA. Today, we are going to dialogue. We are having a dialogue between Dr. Ashok Ladda and me on the SEPTA technique, which is significant contribution of the surgical treatment for the benign anal diseases. Anal diseases include the development of the publication of SEPTA technique with expensive expertise performing 20,000 procedures. He has revolutionized the surgical management of these conditions and benefiting countless patients. He has been awarded by the Lifetime Achievement Award, and which has been given by the Arun Jaitley, a respected government minister. It exemplifies the profound impact of Dr. Ladda has made in the field and his enduring legacy. And the last and most important, he has fulfilling the social responsibility during COVID pandemic time. He singularly established the commitment of the largest oxygen production plant in the state of Madhya Pradesh at Indore. He has delivered numerous orations, keynote addresses, performing several operative workshops and up and down the country and abroad. So I'm so happy. Dr. Ashok Ladda's achievements are countless and the contributions are undoubtedly lastly impact in the field of coloproctology. His expertise, leadership, dedication, training profession make him highly respected and influential figure into the medical. And sir, you are the true hero in scrubs, which I always feel. I have seen your surgery. So today we are having a dialogue, and the dialogue will be very simple, sir. We'll ask the questions. This question, 10 questions, and you are going to. So you can start with some opening remarks, and we can start with the question answers. Sir, over to you, Dr. Ladda, sir.
Me? Am I audible?
Yes, sir. Yes.
Yes.
Yeah.
Kawita, I'd like you to know how much I appreciate your kind comments. I honestly never had known me as much as you just described me. That is, I only had thought that I am a good neighbor of people like you. And we did this program in the last Ekkarsi Khan at Indore, named as Love Thy Neighbors. So my sole objective has been, after I came back to India, after getting proper training, was to establish this specialty, which was being practiced by general surgeons, but there was much more to it than what they were doing. And the primary objective was to give comfort to the patient, because there were lots of myths, and there still are a lot of myths about management of benign anal pathologies, which have a long-term bearing on the quality of life. If they are not dealt with properly, patient gets nightmares and the shivers talking about surgery of hemorrhoids or whatever. So
Yes.
that was the sole objective, and I could do in the best of my capacity working in the private field. So I appreciate you asking me to discuss it out with you. Coming.
Sir, voice.
Coming to this topic of SEPTA, that's what we are going to be discussing today.
So the main, sorry sir, interrupting you. So basically why we gynecologists are interested, the perineal area is basically, we think that, or the females that we think of our area. So I think that the SEPTA, which is you are going to talk about, then first and foremost question that what does the SEPTA stand for? We'll start the questions like this.
Right. SEPTA has now been modified a little since we started propagating it to the colleagues like you who deal mainly with obstetrics. SEPTA means simplified. The technique that I have researched and invented is very simple. So it's a simplified, which can be easily reproduced. So S for simplified, E for easily reproducible, T is for technique of pudendal nerve block. For anal, A is for anal, S is anal surgeries. So SEPTA is a simplified, easily reproducible pudendal nerve block technique for anal surgeries. When I started working in India, I tell you, a lot of credit goes to my colleague anesthetist, who never used to reach in time. And I knew that there are certain things that I could do under local anesthesia. So we started refining our technique, and we struck upon, after all the research, on something called septa, which can very easily be instituted into the patient. And lots of, as far as we are concerned, I do all my anal surgeries under this block. But then lately, realizing that it does help the lower third of vagina, we thought of propagating and popularizing it amongst our obstetrician colleagues for their usage in normal vaginal deliveries, which does involve perineotomy, or what we call episiotomy. It's repair, and also repair of uncontrolled perineal tear during vaginal delivery. And there we thought it does have a lot of scope. So that is what SEPTA, and I tell you, SEPTA is a catchy name, which was given by my colleague, who is also a co-author in this publication, which was published in Universal Diseases in 2018. So a colleague of mine told me that we should give it such a name that people get attracted. So they would at least read it. So this is what the SEPTA is all about.
Sir, so the important point is the name is also good. But can you tell me what exactly it's different from the classical pudendal block? Which the question it comes like, we already given, we all, is it some special difference which you can tell that's a difference between the septa and the classical pudendal block?
Yes, there is a categoric difference between a pudendal nerve block and septa.
Yeah.
I would just enumerate. First of all, septa is given without localizing any landmarks.
Okay.
By that I mean, when you go and do a pudendal nerve block, you have to identify as to where the pudendal canal is, and then you try and reach there. And that involves putting a finger either in vagina or in anal canal.
Yes.
So for anal canal, which is sore, say for if you are going to be treating hemorrhoids or anal fissures, it is discomforting to put a finger into a patient who is already in lithotomic position. The basic objective of septa is to utilize the positioning of the patient, which is lithotomy, and utilize the force of gravity. The objective of septa is that if you can pour local anesthetic solution into the ischiorectal fossa in lithotomy position, by gravity, it trickles down and encircles the pudendal canal. So that is the basic difference between a pudendal nerve block and septa. Two, septa starts not only in theater, septa starts in the ward for cold cases. You have to make sure that the patient is given pre-medication well in time. He is wheeled into the theater very composed and partly slumbered. He gets into theater where we observe reasonable silence. We do not create any noise, because anything done under local anesthesia, particularly in lithotomy position, is a little concerning for the patient and uncomfortable too. So we just bring the patient into theater. There are not many people into operating theater except for surgeon and couple of technicians. And then we just give septa, which takes hardly 45 seconds to give the block. And that is the difference between a septa and the pudendal block. Also, in septa, we go and anesthetize the hypogastric nerve, which is in the presacral area. Normally, for pudendal canal, pudendal block, you do not go into the presacral area, but we go into the presacral area to anesthetize the hypogastric nerve, because that is a parasympathetic supply. And when we do surgery, the tactile sensation of the mucosa is also taken care of. So these are the differences between pudendal block and septa.
Okay, so because of the superior hypogastric plexus and the pre-sacral nerve, the things have really definitely changed. So while doing this, why you have decided why not spinal and GA? This is a question is really I should ask or not, but you have chosen septa over spinal and GA because of your comfort, patient's comfort, and the time it's a anything which you want to talk about. Why not spinal NGN? Why only septa?
Sure, I'm glad you asked it. The contention of doing a septa are very well defined. When we use septa for any surgery, one, minimal of medication is required. By that I mean there is no IV fluid requirement. So we do septa without putting any IV line. We do get an IV access to give them a awake sedation, but there is no IV fluid required. Two, it is customary and perhaps mandatory that if you do any surgery under anesthesia, may it be spinal or general anesthesia, you have to do a complete workup. And by that I mean a workup by a physician and also a cardiologist in cases if that is a requirement. And this is normally done not for sake of your surgery, but for the sake of the anesthetist. If you do septa, taking a good history, going into the past history, you do not really need a proper physician's checkup or a cardiac checkup because you are not subjecting the patient to much of a discomfort to his system. So that is another thing. So your preoperative workup is pretty reasonable because every surgeon like you and me are good doctors first. So we know what the patient requires and we can assess the patient properly. Three, the medication is much less. The post-operative analgesia is much, much better when you do, because septa, as you know, is a preemptive nerve block. So post-operative analgesia is enormous. And so because of all this, the post-operative complications, which predominantly are because of the anesthesia, are totally taken care of. Our rate of urinary retention is less than 0.5%. However, if you go into the literature, the urinary retention after spinal block is something like 15%, which is very high. The cases with the spinal anesthesia do get spinal headache. So even that is avoided. Three, patient is able to walk immediately and he walks to the loo post-operatively. Four, you can start orally immediately the moment patient gets into his bed. And fifth, most important of all, for any anesthesia except for the local block, one need to have a proper consent of the anesthetist regarding the patient being nil by mouth. You can give septa even on the ward bed. I have my colleague in our hospital, I'm sure she must have conversed with you. She got a post-delivery bleed. The patient was brought into the ICU and she was bleeding from the perineal tear torrentially. So she gave septa on the ICU table and controlled ICU bed and controlled the bleeding. So it doesn't require any specific nil orally kind of preparation. That's why this is a better choice.
Correct. Which means you want to say that with this, at least we have effective pain relief, number one. Number two, it's a minimal invasive. I think quick onset is also there. There is the muscle strengths are same. I think sometimes with anesthesia, the muscle strengths also changes, like what I feel. And it reduces the need of systemic medications also. It enhances the patient comfort. And I think general anesthesia ka jo problem it needs of the patient satisfaction. So I'm really happy to know about it. Now, sir, the point comes as an OBGYN, how the septa is beneficial in our obstetric practices. That's what I feel.
The septa, the way that septa block is given, it does anesthetize the lower third of vagina.
Yes.
So it is effective in obstetric practice, mainly for indications like a vaginal delivery. If you give septa routinely to all the ladies who are going to have a vaginal delivery, you can perform an episiotomy without any other anesthesia. And also you can repair perineotomy or episiotomy without any problem. So because we use a lignocaine with 2% lignocaine with adrenaline, even the bleeding is minimal. So you would be able to repair the episiotomy properly, or in case if there is a perineal tear, you would be able to address it better. And that is where we feel. Also, in cases where you need to excise anything in the region of lower third of vagina, may it be a Bartholin cyst or an abscess, you can do without putting the patient into other form of anesthesia. That's why it is useful to my dear obstetricians as well.
So it means we can use it in a second stage of labor, number one, in a vaginal deliveries for the episiotomy repair, and a gynecological procedures like vaginal cyst is there, Bartholin is there, and minor surgeries of the vulva and perineum. Sometimes we have to do, it can be given like that. Now, sir, the
Absolutely.
important point is that we came to know about the septa. Now, the point is, as being a gynecologist, what is actually the learning curve of mastering septa? See, pudendal nerve block, though we know, but we'll use it less and we are afraid ki ye hoga, wo hoga. So, what I feel is anything learning curve of the mastering the septa is there?
Well, like anything else, there is a bit of a learning curve, but let me uh, tell you in simple language.
Yeah.
One, even if you think it has not worked, you do not cause any harm to the patient if you give septa. That is one. Two, the simple fact that all you have to do is just get into the ischiorrectal fossa. Now, as you know, ischiorrectal fossa is a sizable structure.
Yes.
It has nothing but loose, fatty areolar tissue. So, by pouring the fluid into ischiorrectal fossa, you do not need to localize the pudendal canal at all if you do it under spinal anesthesia. So, one, there is hardly any chance of it going wrong. Two, it always works because no matter what you do, if you are able to pour fluid into the ischiorrectal fossa, it has only one way to go, and that is down. It would always trickle down. And I have done studies, and when we present septa, which I am not here to present that, we have done a sonography while injecting the fluid, and our sonologist, a very learned sonologist, could demonstrate that immediately, within no time, it trickles and blocks the pudendal canal. And that is why septa only takes about 20 seconds to work. It works immediately.
Correct. So how much, this, I think we have already talked about the how much fluid or what you prefer for giving the this.
Yeah, like the name says, it is a simplified procedure. All you need is a vial of 2% lignocaine with 1 in 200,000 adrenaline, and to give septa, you need between 18 to 22 ml to give a good block. Which is much less than the safety margin.
Correct. Correct.
So about 20 ml would give you a complete blockage of anal canal and the lower vagina.
Absolutely. So it's being the lower vagina is already being, let's say, blocked with the this setup procedure. So anything which you like to talk about the perineal tear and at plant setting, can we do second degree perineal tear repairs, third degree perineal tear repairs, or 4th degree also?
Yes, whatever cases that I get from colleagues like you, with either a rectovaginal, a low rectovaginal fistula, or anal incontinence because of the perineal tear, I repair them all under septa block, because septa gives me a comfortable operating time of up to 90 minutes. You do not need to repeat it. So 90 minutes is a good time to do a proper repair. So unless there's a high rectovaginal fistula, which is a different ball game, low rectovaginal fistulas, anal incontinence, second degree tear, third degree tear, they can very, very easily be done under a septa block.
Same with rectocele, am I right?
Yes. Well, I do, when it comes to rectocele, another subject, we colorectal surgeons do what we call a star procedure, because we like to resect the rectocele per rectally using the staplers. And I'm the only person in the whole world who does that under septa block as well. The inventor of staplers, the famous Antonio Longo of Italy, who invented the staplers, even now he has started doing all under septa block. He got convinced. He asked me to teach him online how to give septa, and he is ever so happy that he can do everything now without a spinal anesthesia.
Amazing, amazing, amazing. Our own gynecologist will love to watch you online, some workshop somewhere. And anything you want to talk about RVF, you already said that if it's a high RVF, then the thing are different. But the lower one, we can deal with this. Am I right?
That's right. The only thing I would I sent you some pictures of the patient I did yesterday.
Yes.
RVF is a tricky problem.
Correct.
One, as a specialist coloproctologist, I would always deter people doing a fecal diversion. A rectovaginal fistula, I'm talking of a reasonably virgin rectovaginal fistula where multiple trials have not been done, you can repair without doing a diverting colostomy or an ileostomy. The lady that I operated yesterday, and I sent you the pictures, had 2 previous procedures, but I could do her without, and she only came to me because I do all this without any fecal diversion. So you don't need to have fecal diversion. You should, when you do with a rectovaginal fistula, I suggest that you should try and convert it into a 3rd degree tear first, and then you do a proper repair.
Amazing.
Just closing the fistula by putting few sutures is not going to help you. You do a proper repair as you would do for a 3rd or a 4th degree tear, and make sure that you have enough muscle mass between the posterior vaginal wall and the anterior rectal wall. There has to be some padding. Unless you separate them, they are likely to stick again and cause recurrence of the fistula.
Amazing. Yes, absolutely. The perennial body has to be looked after.
Created, yes.
That's the important point. Sir, being a vaginal surgeon, I always remember you each and every surgery, not to make rectovaginal fistula and not to, not to. Sir, I can understand the fear we gynecologists have for the rectovaginal fistula. And with this septa technique, I think it's really amazing that we can deal it, we can learn it, the technique, and we can do things. So any take work home message which you like to give to our OBGYN audience as well as other doctors also?
I suggest that if you really wish to use septa, do that. You may not be doing an episiotomy or a repair, but try and give it to quite a few of your normal vaginal delivery patients. You are not going to put them to any harm. It would give them a very good post delivery or post surgical analgesia. So do that. And it is a self weaning technique. After about 6 hours, patient would just feel normal, and they have a normal voiding reflex and normal defecation reflex. So there is no problem. That is one. True, I think you will have to take the fear away. The greatest fear that any surgeon, may it be gynecologist or a general surgeon, is about the rectal or the anal sphincter. Anal sphincter is a definitive structure. Don't be scared of it. You should know how to do a proper mobilization and a proper repair. It works 9 out of 10 times without any fear. So let the fear go away. Try it in normal cases and see how you go, and then just try it. I'm sure you would all do is as good as perhaps me. Shouldn't be any problem.
Amazing, sir. Amazing. So pain relief during labor and minimal invasive thing, and it's preserve the what they call muscle strength. So the labor pushing of the labor and delivering will be have a great help to the patient. Amazing way of putting things, sir. We all will learn the SEPTA technique from you. And the most important point, which I feel you, thank you so much for joining today. As a one call, you are ready. I'm so happy with the visit of your busy schedule and everything. So thank you so much for joining today, sir. And I think our dialogue will be really beneficial to our own OBGYN.
Well, I appreciate Kawita asking me to be for this particular reason with you all. I really enjoyed it. I appreciate, and I hope I can see roughly 48 people listening to me live.
But they will be more on the YouTube.
Yeah. So I suggest that you try it. Let us know your results, and let us know if I can be of any help to fine tune you. It's a great thing. The best part is that it doesn't put the patient to any harm. Take it that way.
So amazing. The people, somebody has wrote into the chat box that they're enjoying all the discussion, as well as one has said, I have done the ovum pickup with a pudendal blocks, they must be saying, but they will left to learn all the septa technique with them. So, sir, infertility specialists are also going to be benefited by this procedure. So, it's another indication we can add in our list. So, thank you so much for being with us, and each and everyone who has joined today, and probably I must have taken some good message from our program. And be with us. Stay tuned. With many more leaders are there. We are going to talk in the future, and this dialogue should be helpful for everyone. Thank you, Leda sir, for
Thank
being.
you.
Thank you
Thank
so
you.
much.